is a genetically identical person? Monozygotic twins. Monozygotic twins are genetically identical. So these are also called as syngrafts or syngenetic grafts. Third is an allograft. What is an allograft? Allograft is if I give you a kidney or you give me a kidney, that means a transplant of organ or a tissue from one individual to another individual from the same genetic pool but not with identical genes, not with identical alleles. তার মানে it has to be of the same species. Same species মানে the basic gene pool is the same but the individual allelic combinations are different in these. So this is the most common form of transplantation in clinical practice, allograft. And last is xenograft. Xenograft is tissues transferred between two different species. So this is the future. Or allografts are the current practice and the world is working towards a xenograft. Okay, so what is the idea behind classifying the source of donor grafts in this way? What utility do we have? Why are we classifying donor grafts into autografts, allografts and xenografts? What utility does it serve? Any classification we do this classification to predict some either predict or diagnose some sort of a outcome. So what prediction can we make if we classify the grafts in this way? Yes, so very good. So what we do is we identify the chance of rejection of that graft into the host tissue. With this classification we know that autografts have the least chance of rejection. Autografts have actually no chance of rejection because it is from the same body, it is from the same individual, and xenografts have the highest chance of rejection because it is from another different species and the body is identifying the tissue from that species as foreign. So next we come to rejection. This part of the discussion I think you should be knowing better than me. We are more interested in cutting and joining, but you know, at your level this part is very important, not only because of your current examination but what examinations you are going to give in the next few years. All the entrance examinations, a bunch of questions are based on transplant immunology and in very details. Okay, so what is rejection? Rejection is the immune system of any living body is meant to identify or differentiate between two major types of cells. One is their own cell and two is the foreign cell. What is the idea behind it? It is presumed that any foreign cell present in the body is possibly trying to harm the body. So we need to launch an attack on the foreign cell and also to identify its own cells so that the own cells are not harmed in the process. Ke barir lok ar ke bairer lok, we have to identify. That is the job of the immune system of the body. So whenever there is a transplanted tissue from one part of the body to another or one person to another person, the body tries to assess the nature of the tissue, the proteins present on the tissue, to see whether they are own cells or they are foreign cells. This recognition is done in two processes. One is direct allo-recognition and two is indirect allo-recognition. The basic principle is that direct allo-recognition is a faster process whereby the proteins and the MHC present on the donor graft tissue is identified by the T cells of the body directly. Whereas in indirect allo-recognition, it is done by first initial processing of the tissues, of the foreign tissue, identifying the individual foreign peptide which is antigenic, presenting that antigen on by the antigen presenting cell to the recipient immune system, recipient T cell. So this is the process in which antigens are identified and or processed in the transplanted tissue, and then the processing starts. So mechanism of rejection. How does this rejection take place? The initial phase, after the antigen is identified that okay, this is a foreign antigen, the T cells have identified that this is a foreign antigen. Now what happens with it? Anybody who has gone to a bank locker must have seen that the bank locker opens. The opening of the locker is a two-step process. First, you are carrying a key, you go to the bank, you put in that key, but the locker does not open. The bank manager comes and puts in his key. When both the keys are used together and in sequential order, the locker opens. So T cell activation is the intention of the foreign peptide, and this is also a two-step process, just like the bank locker opening. So first, the T cells with the antigen are presented by the MHC. What is MHC? We shall come a little later also. You must be knowing what is MHC. Yes, major histocompatibility complex. So the T cells are presented with the antigen, and second, there is a co-stimulatory receptor ligand interaction between the T cell and the antigen presenting cell. Once these two steps happen in sequential order, only then the activation of the T cell happens. And what happens upon activation of the T cell? The macrophage mediated delayed hypersensitivity type of reaction ensues, which does a lot of things. One is it induces the B cells for antibody production. It releases a lot of cytokines and interleukins, the names of which you are supposed to know. Every step you're supposed to know. And these cytokines induce endothelial cell activation, endothelial cell damage, and eventually apoptosis. Okay, so to summarize this, the antigen is presented to the T cell either by direct or by indirect process. The antigens stimulate the T cell, first by primary interaction and second by a co-stimulatory interaction between the T cell and the antigen presenting cell. This results in activation of the T cell, and the activated T cell stimulates B cell antibody production, and it stimulates release of cytokines and interleukins, which promote endothelial cell activation and which also eventually promotes apoptosis. So this is how a foreign protein induces apoptosis or cell death in the donor tissue. So graft rejection. This process of graft rejection that I described is mainly limited to acute rejection. So what are the types of rejection? What are the ways in which grafts are rejected by the body? There are 4 types. Okay, let us come to it. So hyperacute, acute, chronic, and the 4th one is most interesting, graft versus host disease. Okay, so let us start with hyperacute rejections. What is a hyperacute rejection? Hyperacute rejection is that the moment we place the graft in the recipient body, that very fast the recipient body ensues a reaction on the grafted tissue. So how does this happen so fast? It happens so fast because the recipient tissue already has preformed antibodies to some antigen in the donor. Okay. Fortunately, this type of rejections are very rare now because of very stringent donor and recipient preparation practices. So the main thing that we have to know regarding hyperacute rejection is that there are preformed antibodies, number 1, and 2, important for your MCQ questions later on. So hyperacute rejection is an antibody mediated uh, rejection. What does it do? Because of the presence of antibodies in the body, the moment the graft is vascularized, there is damage to endothelial cells of the graft because of those antibodies, and it leads to thrombosis of the blood vessels. What happens due to thrombosis of the blood vessels? There is mottling of the tissue. On table, there is mottling of the tissue, and there is death of the tissue, and all these things happen between minutes to hours. So it might be possible that if I am transplanting a kidney, I have vascularized the kidney, and immediately the kidney turns black and dies on table in front of my eyes. So this is the magnanimity of hyperacute rejections. So you might ask me, why do these preformed antibodies, where do they come from? So preformed antibodies come from, most commonly, from a previously transplanted kidney, or with recurrent pregnancies, the mother might get exposed to antibodies of the fetus which are not self. So the mother might have preformed antibodies to certain um, and lastly, viral infections, viral epitopes might also mimic many body parts, and these are the three most common scenarios in which preformed antibodies are found, and it needs to be screened before we prepare a patient for transplant. Number two is acute rejection. Acute rejection is the most common type of transplant that we occur. How does this happen? We have discussed how does this happen. First, there is a sensitization phase whereby the antigens are recognized by the body, and then the effector phase whereby the antigens are, where the T cells are activated by the antigen, and this leads to release of cytokines and induction of B cells for antibodies and apoptosis. So, why knowing acute rejection is important? Acute rejection is important because every patient, in spite of proper preparation, in spite of proper selection, has a chance to undergo acute rejection. So we need to treat this patient. Now, hyperacute rejections are not treatable, but acute rejections are treatable. Why? Acute rejections are treatable because of this sensitization phase, which means that the body is taking some time to develop the defense mechanism against this foreign peptide. The body is trying to build antibodies, the body is trying to launch an attack, and this takes few days to few weeks time. So if we can identify a patient with an acute rejection or the possibility of an acute rejection, we can give treatment to the patient and stop the process at the sensitization phase so that the effector phase does not begin. If the effector phase does not begin, then the damage, the end cell damage, does not take place. Clear? So how do we recognize acute rejections? I can give you clinical scenarios with kidney transplants. So what we do is, if after transplantation the patient develops a resurgence of proteinuria, the patient has a hematuria, proteinuria, fever, or graft dysfunction, the return of kidney function is not adequate, then we immediately start to look for other clinical parameters which can detect whether this is an acute rejection or not. So how do we detect an acute rejection clinically? What happens? What is an acute rejection? It is an inflammatory reaction in the body. So most commonly, all the inflammatory markers of the body rises. Can you name a few inflammatory markers? Very good. Anything else? Interleukin 6, 12 we measure, C-reactive protein we measure. Okay, so the patient having organ related signs and symptoms with increase in inflammatory markers. So the moment we diagnose the patient having these symptoms, we launch an attack against the sensitization phase so that it does not propel into the effector phase. Good. So next common is the chronic rejection. Chronic rejections are a pain. Chronic rejections are a pain. Why? Because it's a multi-pronged approach. It is both humoral and cell mediated, and there are multiple mechanisms which are non-immune also, which eventually lead to chronic rejection. Chronic rejection takes months to years, often years, and there is no way to stop it or prevent it or treat it. Chronic rejections we cannot treat. It is an irreversible process and no treatment is available. And histopathologically, it leads to graft fibrosis. So once the tissue is fibrosed, there is no functional capability of that tissue, and so the the tissue becomes non-functional. Last is a very interesting immunological phenomena. It has been discovered only after starting transplants with hematological products. It is most common in bone marrow transplants or stem cell transplants, where the immune system of the transplanted tissue launches an attack on the antigens of the donor tissue. Okay, it's the reverse immunological cycle, whereby the donor is not finding the recipient graft as foreign, whereas the opposite is happening. The recipient tissue is finding the donor host tissue as foreign and launching an attack on the host tissue. Okay, so these are the 4 types of graft rejection. What do we have to remember? We have to remember that hyperacute rejections are antibody mediated, preformed antibody mediated. Acute rejections are mostly T cell dependent reactions. Chronic rejections are a pain. It is multi-pronged. All mechanisms, both immune and non-immune, are involved in it. And lastly, graft versus host disease. So all this time, when we are talking about transplant, we are talking about rejection, right? But rejection is something that we don't want in a transplanted patient. We want the patient not to have a rejection. So how do we go about it? Preventing a rejection is a 2-pronged approach. One is you select the ideal donor for the particular recipient, and number 2, you prepare the immune system of the body so that it becomes capable of receiving a foreign protein. You get my point? So it's a 2-pronged approach. This slide describes the first half of it. So what is the first half? Pre-transplantation preparation. How do we prepare and select the patient for transplantation? So what we do is we do matching of antigens and antibodies. We do a blood grouping match between the donor and the recipient, and we do a MHC match between the 2 recipients, and then to further verify our findings, we do a cross match. Okay, so say a patient is having blood group A. What is the antigen antibody profile for this patient? Can anybody volunteer? What antigen does the patient have and what antibody does the patient have? Yes. Bolo. So we are very accustomed to this blood grouping strategy. We know that even when blood is transfused, we have to match the antigen antibody profile of the blood groups. Same for transplant. It is essential that we have a blood group match before we do a transplant. Next is MHC typing. What is MHC? You just said the full form. MHC is present in Major histocompatibility complexes are present in all organisms. In human beings, it is present at the human leukocyte antigen. This is all, again, a very boring bit of information, but it is very important for your MCQ classes. It is present in the short arm of chromosome 6, and this HLA gene codes for major and minor classes of alleles. What are they? There are three major classes of alleles. In class 1 alleles, there are HLA ABC, and three major class 2 alleles. They are HLA DR, DQ, and DP. So the matching, importance of matching about this is there should be at least a 50% match of HLA between the donor and the recipient. So it is very difficult to get a complete HLA match. Why? Only monozygotic twins have a possibility of HLA match, and normal siblings, the 25% chance of normal siblings getting an HLA match. Why is this so? Because HLA is transmitted chromosome wise. So the mother has 2 chromosomes, the father has 2 chromosomes, the sibling gets either of the chromosomes, say 1 2 3 4, so either 1 and 3. So there is a 25% chance of getting a match between siblings, and 100% match is only there in monozygotic twins. But it is not possible that every patient requiring a transplant will have a monozygotic twin or a sibling with good match. So we need to see whether there is a maximum match of HLA between the between the recipient and the donor, so that the rest of the mismatch can be managed by immunosuppressive agents. Okay, so even after doing a blood match and a positive HLA match, there is always another third precautionary step to match the donor antigen and the recipient sera to see whether there is any immunological reaction. Why? Because this is the last cross matching assay is done to identify preformed antibodies. Okay, so these are the three immunological tests that we perform before selecting a donor and the recipient, so that we can reduce the amount of antigen mismatch. And lastly, what is the other approach to prevent an antigenic reaction in the body? The second approach is immunosuppression. So we prepared the patient with immunosuppressive drugs before the transplant, during the transplant, and lifelong, so that even if there is some sort of mismatch between the donor and the recipient, that antigen antibody reaction and final effector response is prevented by medication. So these immunosuppressive drugs are basically of, I think I've made a mistake in the slide. Anyways, there are basically of two types. One is general immunosuppression, whereby we decrease the total immune capacity of the body to any kind of foreign antigen, may it be bacterial or viral. So there is a general immunosuppression. This is brought about by mTOR inhibitors, anti-proliferative agents, steroids. You must have studied these in detail in your pharmacology classes. Okay, and next is the other category is specific immunosuppression. Specific immunosuppression means we are using monoclonal antibodies, and these monoclonal antibodies are directed to specific receptor level targets to prevent specific steps. For example, basiliximab is an interleukin 2 receptor antagonist. Belatacept is a CTLA4 co-stimulatory signal antagonist. So are we aware of these drugs? Have we? Yes. So can somebody teach me what is a CTLA4 receptor antagonist doing? Anybody has any idea regarding this? কিছুটা ঠিকই বলেছো. Anybody having a better idea? So CTLA4, I just mentioned some time back regarding a co-stimulatory signal. Do you remember? Yes. So the co-stimulatory signal involves a ligand and receptor binding, which is the second key. Now CTLA4 is a inhibitory receptor. So this co-stimulator, if CTLA4 is activated, then the pathway is inhibited. So these are not so important for me nowadays. Anybody already in clinical practice, the details of these signaling pathways are not important, but for you it is very important. You must go through your microbiology and your pharmacology textbooks to really understand the immune mechanism and learn about these drugs and these immune passages in detail. Okay, so what I tried to do today for you is that I give you an overview of the immune system that functions during a transplant, for a transplant patient. Now, to give you a brief idea clinically how things happen, in case of a kidney transplant, like I just mentioned, we prepare the donor and the recipient by doing first a blood cross match, then an HLA cross match, then uh, Sera cross match. Okay, once these are positive, then we do a transplant, prepare the patients for transplant. How is the transplant done? Transplant is done by, we start immunosuppressive agents 1 day or 1 week depending upon the clinical situation before, to the recipient, to prepare the recipient immune system at a lower level than its normal activity so that it can harvest a graft. What are the normal immunosuppressive agents that we use for a regular kidney or a liver transplant? It is usually a 3-drug strategy. We use a tacrolimus, we use mycophenolate mofetil, and a corticosteroid. So these are the 3 drugs which are used in combination, and induction is done by monoclonal antibodies to isolate and block the effector pathway. Okay, so it involves an induction phase of immunosuppressive drugs followed by maintenance of 3-drug regimen, which includes tacrolimus, mycophenolate mofetil, and corticosteroids. Once we have prepared the recipient by decreasing its immune potential, then we transplant the organ. Transplant involves harvesting the organ from the donor and reimplanting on the recipient. So, for a kidney, what do we mean by reimplanting? What do we do by reimplanting? Anybody can tell me what are the steps that might be involved? This is a surgery class, so I'm just venturing into the surgical aspect of one transplant. Anybody has any idea? For a liver transplant and for a kidney transplant, what do we mean by reimplantation? What does the surgeon do? Bolo bolo. না, orthotopic heterotopic বুঝলাম. Orthotopic heterotopic is about where we are placing the graft, whether we are removing the primary organ or not. So reimplantation means you have to revascularize the graft first. That means we have to put in a connection for the artery so that blood goes into the tissue. We have to put in a connection for the vein so that blood comes out of the tissue. Now the kidney is vascularized, blood is going in and coming out. What is happening to the kidney? Kidney is producing the urine. So now we have to transplant the ureter back into the urinary bladder. Did you understand? So transplant means anatomical normalization of the graft in the body. Skin transplant, just you have to put the skin on the recipient area. Whereas organ transplant, solid organ transplant involves re-establishing all the normal channels that are present in the body. So if I gave you an example of the kidney, can somebody volunteer what needs to be done for the liver? Tell me. So again it involves arterial venous connection and an output for the bile. ঠিক আছে? Regarding rejections, the mainstay of treatment for rejections are corticosteroids. First step, that is how we start our treatment. And since you are becoming doctors in another year's time, transplants don't happen the way they are shown on television or movies. It is more complicated, it is more interesting, and it is very fascinating.